Right, so this is a study by Goldstein in 1988. Remember, we use it for various things like validity of the DSM or different reliability of the DSM. It's our study for schizophrenia. So much like if it asked you for a study about depression, you use Brown. If it asks for a study on schizophrenia, you use Goldstein. It looks at primary and secondary data, and it's a longitudinal study. But again, it's perspective rather than retrospective, which is good. So Goldstein wanted to answer the question: do women suffer schizophrenia or have less severe schizophrenia than men? This was a big belief at the time. And we also, secondary, wanted to look at diagnosis between the DSM and the DSM-2 and DSM-3. So the aim was to see if there is gender differences with regard to rehospitalisation between men and women, and look at social factors which could be a factor in that diagnosis. So the sample consisted of people who had a hospital diagnosis of schizophrenia or acute schizophrenia on admission, had a hospital stay of less than 6 months, and were expected to return to their family, had no mental health issues other than this, and had no history of drug abuse or alcohol abuse, aged 18 to 45. So it was a single blind technique. Remember, the psychiatrist or the doctor diagnosing the illness had no idea what the hypothesis was. He didn't know why he was doing this. So he couldn't have introduced bias based on what he wanted to see. So all he did was diagnose these men or these women, and then look at kind of analyze the data about their history. So of the original 199, 169 met the criteria in the DSM-3 for schizophrenia. We were particularly looking at first-time admissions, but that wasn't a very big sample, so we did add more people in. The mean age of these was 24. So the men and women didn't differ in terms of age, education, or class, but they did have different job statuses, with the women having more white-collar jobs, the men having more blue-collar jobs, or being unemployed. So we looked at how well the patients could function in everyday life. So we looked at marital status, occupational status, peer relationships, their isolation from others, and their interests. This gave us a relatively quick picture of how they dealt in everyday life. We looked at particular symptoms of schizophrenia as well. This is how they were assessed and measured. So we looked at hallucinations, paranoia, isolation, their level of withdrawal, inability to function, whether they had obsessive thoughts. We looked at lots of different symptoms like this. We measured their pre-morbid functioning. So remember, this is how well they functioned or how well they got on in society or in company before their diagnosis of schizophrenia. This was done by a questionnaire dealing with them in 2 separate age groups. Pre-morbid functioning was again measured by the various things like isolation, whether they were married, occupational status, and things like that. And we measured them over a 5-year period and a 10-year period, looking at A, the number of hospitalizations they had, and B, how long they stayed in the hospitals. So these are the findings that we get. We can see from this, so I'm just going to try and delete the boxes that are on the background of this, and it's not going to let me. So men stayed in hospital, men were rehospitalized twice as much as women. They, again, the same later on at the 10-year period. At the 5-year period, they spent an average of 267.4 days in hospital, and women 129. So, sorry, I've got the hiccups now. And we can see that, so basically, men stayed in hospital twice as long as women, and they were hospitalized nearly twice as many times. So the research question looked at whether men or women suffered schizophrenia differently. And it turns out women had a significantly lower number of rehospitalizations, and they spent less time in hospital. A lot of this, though, or some of this, was accounted for by pre-morbid functioning. So basically, men got schizophrenia worse because their lives at the start of the study were worse. I'm doing inverted commas there. They were more isolated and things like that, which meant that schizophrenia had a bigger impact on them. So in conclusion, females suffer schizophrenia less than men, and the gender difference was strong enough even with the DSM, which is more stringent than the DSM-3, sorry, which is more stringent than the DSM-2. But also that tells us, as I know Catherine likes to mention, that 30 people were now no longer diagnosed with schizophrenia. So that's the Goldstein study. We've got some evaluation points on that. 2 seconds, evaluation points on that when it loads up. That's a very brief summary from the mark scheme, by the way. Evaluation points uses quite a large sample, using both men and women. They were matched on characteristics, so that removes participant variables. But remember, a problem is that women tend to get schizophrenia after the age of 45. We included women before their peak age of schizophrenia and men who were right in their peak age. So it might not be surprising that men did have schizophrenia or worse, whereas if we tried women when they were older, we might have found a more balanced picture. This supports a study by Angermeyer, which found the same thing in Germany, exactly the same thing pretty much. This is an objective, numerical way of measuring things, although it uses interviews, or questionnaires, sorry. So there's again some social desirability. It's longitudinal, so that's good and bad for the reasons that you are aware of. And remember, this is a prospective study rather than a retrospective one, which means that it's better for cause and effect. Remember, the problem with retrospective is we can prove anything looking back, whereas with a prospective study, we get much better cause and effect. So now we can start looking at the theories or the explanations of schizophrenia. First, we have to look at the symptoms. So these are the common symptoms of schizophrenia. Delusions such as persecution or grandeur. So delusions of persecution are believing that the government is out to get you or something like that. Whereas delusions of grandeur are those kind of grandiose ideas where you believe you are Jesus or you believe that you are Napoleon, something where you believe you are special or different for whatever reason. Likely to suffer from hallucinations, whether that's auditory, so hearing voices, or visual, like seeing things. They may show lots of negative symptoms. So they might have poverty of speech. Remember, schizophrenics often lose the ability to express themselves or speak clearly. They might have a flatness of affect, so they might lose emotion or show inappropriate emotion. These negative symptoms get kind of especially traumatic or obvious when they have catatonia, where they go into a catatonic stupor and they become immobile. Waxy posture leads on from this, so if you raise somebody's arm, they will remain there and it will not move. And they also have difficulties interacting, social problems. So, for example, some symptoms include, as given in the mark scheme, hallucinations, delusions, poverty of speech, sort of losing speech, lack of emotion, and problems kind of bathing themselves, personal hygiene, general social behaviour, normal behaviour. I've got a little more about this on my slides, which I will quickly show you now. So remember, you have to have so many of these symptoms. In order to be diagnosed, you need to have 2 of these symptoms for more than 1 month and reduced social functioning. Or you can have only 1 of the symptoms if your delusions are bizarre. So, like, not just believing that you are being followed by the government, but that they are living inside of your kettle, whatever. Or if your hallucinations, your hearing voices, are Schneiderian, which means that you've got 2 voices which either argue with each other or narrate your life. Remember, we could have also included up to a certain point the 5 different types of schizophrenia and the 5 subtypes. Paranoid, catatonic, disorganized, residual, and undifferentiated. Again, you can pause these and have a look at them if you like. You need them in like a couple of words, really, to summarize what happens during them. But as of DSM-5, this is no longer the case. They have been removed. Again, we can question whether this boosts in validity or lowers reliability. So that's a bit more about the symptoms of schizophrenia. I'm going to try and get one of the explanations done now before I move on to the next video. So we've got the biological explanation of schizophrenia. So remember, this is that they have excessive dopamine, or it could be excessive activity of dopamine on the synapse, excessive receptors basically, for some reason, they are getting the effects of dopamine more than they should. It doesn't necessarily mean they have more dopamine, but it's something that makes them more sensitive to it. Dopamine is a neurotransmitter, so basically, if they've got too much or it's too active, it's sending too many signals. This means that the brain is too active. So they have hallucinations because the brain is too active. Overstimulation in the mesolimbic pathway, remember, leads to positive symptoms. That's just a part of the brain going from the limbic system outwards. Meso means across. Whereas if they have overactivity in the mesocortical, that gives us negative symptoms. Problems with dopamine functioning in the pathway connecting the midbrain and the frontal lobes. I've already said that. That's the mesocortical area. It doesn't mention it by name in this mark scheme, but that is the mesocortical area. Remember, if we're talking about this dopamine thing, it can be, again, excessive receptors or too strong a reaction, but also the diathesis stress model can be used to compare this and look at it with social. Remember, this is the one that shows that you need a certain amount of genetic or biological cause, and you need an environmental factor to trigger it. And we could also go on to talk about genetics. So genes could be the reason for this, for these symptoms. There may be a genetic mutation needed to trigger this. Again, that links back to the diathesis stress model. And this genetic mutation might cause that excessive dopamine. The reason people may have excessive dopamine is because of genetics. Or that could also cause you to have more receptors. Basically, your genes are different from average, which causes this difference. Gottman and Shields is a study which again shows MZ twins have a greater concordance than DZ twins, therefore it is biological. We can evaluate this using, there's so much information on this. So we've got the studies in our little study booklet that I gave you, which summarise lots of studies about this. They're also obviously in your handouts and on the slides. So Griffiths is one of them, Griffith et al. 1972. And this is one where we looked at what the effects of amphetamines. If we give somebody amphetamines, a drug like cocaine or LSD, what we see is that they have symptoms associated with schizophrenia. So LSD and cocaine can both result in hallucinations, which is what Griffiths found. In your handout, you'll find a lot more information on this, including the links to L-DOPA. Remember, Parkinson's and L-DOPA are very linked to schizophrenia. But there are problems with this. If this was true, then the drugs we give you to cure schizophrenia, which remember lower dopamine, would work instantly. The medication would sort you out straight away. But they don't. They take a while to kick in. So it's not just dopamine that's important. There must be other factors involved. But again, the medication does go some way to curing people. Therefore, it must be partially true. We can talk about how dopamine may just be a result of schizophrenia, not the cause. So perhaps dopamine, having high levels of dopamine, is a symptom of schizophrenia and not the underlying cause. So we can talk about other things as well, like how this ignores the social explanations, so it's reductionist, and you could bring in diathesis stress model to kind of bridge the gap between them. Genetics, obviously, Gottman and Shields and Gottman act as support of this. And just the other few facts point out that you can't rule out the environment. Again, diathesis stress model. The concordance isn't 100%. If it was purely genetic or purely biological, we'd expect 100% concordance. And there's a large number of genes involved, so it's not simple just to say one mutation. So it's a too simplistic view of things. And obviously, T of the Scout model is that all of this is biological, objective, scientific, and so on. Right, so next I'll try to cover the rest of schizophrenia in the next video. This set of videos, by the way, is clearly going to be longer than 6. So if you're listening to these in concurrency, you'll see these in a second. Bye.